Bismillahirrahmanirrahim. Schistosomiasis by Khaled Abo Bakr Khalaf, lecturer of tropical medicine and gastroenterology. Overview. Schistosomiasis is an acute and chronic parasitic disease caused by blood flukes of genus Schistosome, described for the first time by Theodore Pilhares. It is the third leading endemic parasitic disease in the world, after malaria and amoebiasis. WHO reported more than 240 million cases spread out largely in about 80 developing countries. It is estimated that at least 90% of those requiring treatment live in Africa. There are two major forms, intestinal and urogenital, caused by 5 main species of blood flukes. Intestinal schistosomiasis caused by Schistosoma mansoni, Schistosoma japonicum, Schistosoma mycogeni, and Schistosoma intercalatum. Urogenital schistosomiasis caused by Schistosoma hematobium. As we see, the distribution of schistosomiasis all over the world. It's mainly in Africa, South America, in Asia, but mainly in Africa. Epidemiology in Egypt. It is one of the major health problems in Egypt. Infection may be by Schistosoma hematobium or Schistosoma mansoni. Infection occur early in childhood. Male to female ratio is 9:1. Infection occur at area with close contact to water-rich in snails. Lifecycle. Infection occur by penetration of the skin by Cercaria. Cercaria lost its tail and became just small. Small reach the circulation, migrate to portal system in the liver, and mature to adult worms. Adult worms migrate to vesical veins and mesenteric veins to lay eggs, which penetrate the wall of urinary bladder and rectum, pass in urine and stool. Some eggs circulate back to the dermatitis or swimmer itch. It occurs due to Cercaria invasion, which include dermal and subdermal inflammatory response. More with Schistosoma mansoni, itchy maculopapular rash, self-limiting, local glucocorticoids in resistant cases. Acute schistosomiasis, mainly asymptomatic, but in some cases fever, lymphadenopathy, eosinophilia, CPC, stools and urine analysis for evidence of overdiagnostic activity. Treatment by systemic glucocorticoids followed by praziquantel. Hepatic schistosomiasis. Pathology and pathogenesis. Schistosomal hepatic fibrosis is a chronic condition caused mainly by Schistosoma mansoni and in 20% by Schistosoma hematobium. The ova are deposited in the fine portal tributaries and liberates soluble egg antigen, which stimulate immunological reaction. The sensitized T lymphocytes migrate towards the ova and secrete lymphokines. This stimulates future migration of lymphocytes and eosinophils and macrophages. These cells encircle the ova, form the granuloma. Collagen is deposited in the granuloma and fibrous tissue is formed. There are two types of fibrosis: fine preportal fibrosis and coarse preportal fibrosis. Fine preportal fibrosis, there are few ova deposited around small portal veins. The fibrosis is mild. While coarse or pipe stem, there is large number of ova deposited around large portal veins. There is gross fibrous thickening. Stages: hepatomegaly stage, hepatosplenomegaly stage, splenomegaly stage, and acidic stage. Firstly, hepatomegaly stage. The liver is mildly enlarged. It may be soft or firm. Hepatosplenomegaly stage. The liver becomes more enlarged and the spleen is moderate. Splenomegaly stage. The spleen hugely enlarged and the liver is shrunken. Portal hypertension is marked in this stage. Acidic stage. Ascites appear with evidence of hepatocellular failure. These stages are not constant and great overlap may occur. Schistosomal hepatic fibrosis is not true cirrhosis. Difference between liver cirrhosis and bilharzia fibrosis. In liver cirrhosis, hepatocellular failure is predominant, while in bilharzia fibrosis, portal hypertension is predominant. Rectal snip in both. It is normal in liver cirrhosis, but bilharzia lesion detected in bilharzia fibrosis. Sonography, shrunken liver in cirrhosis, preportal fibrosis and portal hypertension in bilharzia fibrosis. Liver function test markedly changed in liver cirrhosis, while minimal changes occur in bilharzia fibrosis. Hepatitis more frequent in liver cirrhosis, but it is occasionally occur in bilharzia fibrosis. Pathology: in liver cirrhosis, it's cirrhosis and degeneration and regeneration dual, while in bilharzia fibrosis, it's fibrosis and granuloma association. There is risk factors of hepatitis in liver cirrhosis and the history of schistosomiasis in bilharzia fibrosis. Clinical picture: it may be asymptomatic. Symptoms of huge spleen, racking pain in the left hypochondry, abdominal distension and edema in lower limbs, hematemesis or melena. Investigation: abdominal ultrasonography reflects the gross pathological changes. It shows evidence of preport thickening. Upper endoscopy shows esophageal varices in case of portal hypertension, sigmoidoscopy and rectal snip for schistosoma ova of all the infection. Circulating schistosomal antigens. In CBC, there is anemia secondary to bleeding or hypersplenism. Leukopenia and thrombocytopenia may be due to hypersplenism. Liver function test in pure schistosomiasis may be normal. Liver biopsy show evidence of schistosomal hepatic fibrosis. Treatment: anti-schistosomal drug, praziquantel. Treatment of complication: bleeding varices. We do band ligation or injection sclerotherapy. Hepatic encephalopathy, we give medical treatment, and finally in end stage liver disease we can do transplant. Bilharzia colitis. Pathology and pathogenesis: it is caused by Schistosoma mansoni and Schistosoma hematopium in 5%. Ova are deposited in submucosa of descending colon, where they produce reaction. The overlying mucosa becomes thickened, granular, and may ulcerate. The overlying mucosa may be atrophic and giving picture of sandy patches. Intestinal polyposis results from excess accumulation of granulation tissue. Complication: intestinal and extraintestinal. Intestinal include fibrosis, stricture, prolapse, intestinal polyposis, and protein losing enteropathy. Extraintestinal in form of bilharzia, hepatosplenomegaly, and portal hypertension and other complications. Clinical picture: mild abdominal discomfort and diarrhea, bloody diarrhea or bloody diarrhea, tenesmus, and stool incontinence. Excessive polyps produce blood loss. Picture of complication either intestinal or extraintestinal. Investigation: stool analysis for detection of ovum, sigmoidoscopy, diagnosis acute inflammation, sandy patches, ulcers, and polyps, rectal snip, and direct microscopic examination for detection of eggs, detection of schistosomiasis. Treatment: praziquantel 40 mg per kg once, endoscopic pulpectomy, surgery in case of stricture, prolapse, and polyposis. Prevention and control: health education, mollicidal, sanitary water and sewage disposal, mass treatment. Thank you.